Thank you. This is Steve Adelsheim, and I am very excited to be able to introduce our speaker today, Dr. Scott Woods. Scott is one of the people that I met very early in my involvement in clinical high-risk work because he's been one of the experts in this field for a very long time. Dr. Woods is a professor of psychiatry at Yale and the director of the Prime Clinic for the Attenuated Psychosis Syndrome. He is one of the people that worked on the development of the SIPs, which we've been hearing about over time as well, and it's really become our premier tool around understanding where people are on the continuum around psychosis. And I'm just very excited that Dr. Woods is willing to spend the time with us today to educate all of us around prescribing psychotropic medication for people at clinical high risk. So without further ado, let me hand things over to Dr. Woods. Let me thank all of you for joining. Please introduce yourself, and as questions come up during the discussion, please post them on the public chat so we can be ready to address them later on in the presentation this morning or this afternoon, wherever you are. So thank you, Dr. Woods. Appreciate it. And welcome.
Great. Well, thank you, Steve, for that very kind introduction, and thank you for SAMHSA for the invitation. And I'm really happy to be here today, and I'm looking forward especially to the discussion section because we're all learning in the clinical high-risk field, and so I'll be giving the benefit of my experience and my published studies from the literature and also a little bit of unpublished data, but I'm interested in learning from the participants as well. So thank you. So to start with the, and can you see my pointer? Can people see my pointer?
No.
No, okay. So the learning objectives are to understand the principles of stepped care and the role of the prescriber in the CHR clinic. And this is going to be, both of these are going to be areas where there's room for a lot of practice variation, which is understandable at this stage of the development of our knowledge about CHR. And then become familiar with the evidence base regarding antipsychotic prescription, which is probably the most important class of medication to talk about, and to become familiar with the role of medication in managing comorbidities in CHR. So these are my disclosures, and I'm embarrassed that there aren't more of them, but I do some consulting for pharmaceutical companies, but I won't be talking about any of their products today, or although I will be discussing off-label uses of the medications. So one of the interesting things about clinical high risk is that there are really two goals of treatment. And one goal is to reduce the risk of the patient becoming psychotic in the future, so that's a prevention goal. And then the second goal is to improve their current state, either their symptoms or their CHR symptoms or comorbid symptoms like depression and anxiety, and to improve their functioning. People sometimes get hung up on this, this dual nature of the clinical high-risk syndrome, and they feel like it needs to be one or the other. It needs to be either prevention, which would be the reducing the risk of psychosis, or treatment, which would be improving current state, but it can't be both. And I actually don't feel that way. I think it maybe is a little bit unusual to think about diagnosis as having both a current treatment and a prevention component. But actually, it seems to me that we do this really all the time. For example, when we treat patients with depression, we try to improve their current symptoms, and we also try to reduce their risk of suicide. And so we're always doing, in my view, always doing both treatment and prevention, and it's a little bit of a false dichotomy. But it does come into play, particularly with the naming of the syndrome. So sometimes, so for example, the researchers use the term clinical high risk now, but as you probably know, the DSM-5 uses the term attenuated psychosis syndrome, which doesn't mention the risk. So it continues to be an area of active interest in the field. So what does the prescriber do, whether it's a psychiatrist or an APRN or a PA? Well, I would say this is what the psychiatrist does in our clinic, and I imagine that the psychiatrist does different things in many of your clinics, and so, or the prescriber, I should say, and I'd be interested in hearing about that. In our clinic, the psychiatrist does general medical assessment and has a meeting, a single meeting with the patient at the beginning of treatment, whether the patient gets on is prescribed medication or not. And one of the reasons is for a general medical assessment, which frankly is pretty low yield. We did have a patient not too long ago that turned out, a prodromal or CHR patient who turned out to actually have a brain tumor. But we did not catch this on our medical assessment. We were doing some research MRIs, and we caught it on the research MRI. So, and there was nothing about the case that really stood out. But this is a very rare thing. I would say we've evaluated over 1,000 people for CHR, and this is the first brain tumor that we've known about. But we still feel like it's good to do, and we get some routine screening labs, and sometimes these patients haven't really even seen any kind of medical provider. The other, we also do, the psychiatrist also does a comorbidity assessment to see whether, in addition to the CHR symptoms, there are significant symptoms of anxiety or depression. There's a safety assessment with regard primarily to suicide. And we feel like this is a good baseline, because if later the patient has problems, the prescriber has a baseline assessment of these things and can come in and kind of update the safety assessment with already knowing the patient a little bit. So, and that we believe keeps us from needing to always send them to the emergency room, for example, if they mention suicidal ideation for the first time in one of their therapy appointments. But the prescribing overall we view as adjunctive to the psychotherapies. We view the psychotherapies as the primary treatment, and the target of the prescribing is primarily their comorbid symptoms and comorbid disorders. We don't really have any medications that are of clear-cut benefit specifically for the target CHR symptoms yet. I hope we will before I retire, but at the moment our target is primarily on the comorbid symptoms. Except when the risk of conversion to psychosis seems to be extremely imminent and or associated with suicidal ideation. And we'll talk more about that under the antipsychotic section. There's different ways of thinking about stepped care. The overall idea is to give on the next slide, to give lower risk or less severely ill patients a more readily available and less intensive treatment, and to give higher risk or more severely ill or patients that failed to remit with the less intensive treatment a more specialized, more expensive, or riskier treatment. And we reserve antipsychotic medications only for those as I've already said, and will say again several times, only for those at highest risk of developing psychosis or the most ill or rapidly progressing patients. So there's different ways of, because there's, there's two ways of conceptualizing the CHR syndrome. You can potentially stratify your care based on symptom severity or functional status, possibly based on comorbidities, depending upon the kind of psychotherapy that you're going to be giving. And if you're interested, let's say you're doing a trauma-based kind of therapy, and you might stratify them based on whether they've experienced trauma or not. And in our clinic, we're using the Naples risk calculator, and we calculate an individualized risk for each patient, and we stratify the care based on that single individualized risk of conversion number. I think I'll have a slide about the risk calculator a little bit later. Well, here it is. So this is what it looks like. There's 8 variables from the literature. It was derived from a large sample of patients at clinical high risk for psychosis. It's an online calculator, and so you log onto the website, and this, unfortunately, we're not going to be able to do that here, but because this is just a screenshot, but you can see you can toggle these various measurements. You have to have done a SIPS interview to qualify for this individualized risk, and then a couple of individual neuropsychological tests, and some stressful life event and traumatic event rating scales. But depending upon their level on each of these 8 features, you'll get a little box there to the right which tells you what their individualized 2-year risk of converting to psychosis is. And in this particular set of toggles, it was 40% over 2 years. That's high. Most patients who do this are in the 10 to 20% risk range when they first enter. To get into the medication area, first I'm going to just talk about the medications that, in our experience, are used in clinical practice for these patients, and these are based on the large Naples samples, and it's the treatment that they received not during the study, in this case, because the study actually didn't provide any treatment. It was just a naturalistic observation. So this is community treatment that they had received before they entered the study. You can see that about 40% of them had been already prescribed some kind of psychotropic medication. This is for the Naples sample. I guess this would vary depending upon where your patients tend to come from. In Naples, quite a number of the patients were referred from other mental health providers. But if you were, say, to get all of your patients from perhaps from a school nurse, for example, then you might have a lower rate there. The Naples 2 sample had about 20% of people already on antipsychotic medication, a little less, and that's held up in Naples 3. The Naples 1 rate was lower because some of the sites didn't accept patients who were on antipsychotic medication in Naples 1. About 30% on antidepressants, and a smattering on other classes, stimulants, mood stabilizers, and benzodiazepines. We're going to move into the antipsychotic section here of the talk now, and first there are basically 3 randomized studies, placebo-controlled randomized studies. of antipsychotics in clinical high risk, which is only 2 of which are published, which is a really poor track record for 20 years of research, but that's what we have. This first one was one of the first ones done, olanzapine versus placebo. It was started in the late 90s when olanzapine was popular, and the risks associated with olanzapine weren't really well known at the time we started the study. It was funded by the manufacturer, the Eli Lilly Company, and there were 4 sites. The patients on average took about 10 milligrams per day, and a little bit higher in the placebo group in terms of the dose, which in my view is actually a mark of the quality of the study, because that means that the dose in the active treatment arm was a little bit limited by side effects, and which it should be. So I think for a good study, the placebo dose should be higher than the active dose. Adherence rates were quite good, at least over the first 8 weeks, and all patients received supportive psychotherapy. This is what the prevention aim of treatment looked like. And there were only 60 patients randomized in this study, and as you can see, although the threshold for statistical significance is p.05, this study had showed a p-value of p.06, and it's usually quoted in the literature as being not significant, which is true. It wasn't significant, but there certainly is a suggestion of some preventive power here, and especially after, right at the beginning is when the dose titration phase was, and so quite a few of those early converters in the olanzapine arm were only on 5 milligrams a day. So in the few cases that you do use antipsychotic medication, although low doses are to be preferred in general in young patients out of an abundance of caution, there's some evidence that actually regular doses are needed, or would do better than low doses in this condition. Not everybody agrees with me on that. What about the symptoms? So the left panel is from a study of the first 8 weeks, and there was a statistically significant improvement in the positive symptoms over the first 8 weeks, and that second panel shows the rest of the first year of randomized treatment, and that improvement was maintained over time. So good evidence for improvement of their CHR symptoms with olanzapine. However, which in retrospect was very obvious, but wasn't obvious at the time, was a big problem with weight gain, which not only is a big problem with olanzapine in general, but it's also age-related. So the younger the young patients in the adolescent age gain even more weight than regular adults, who gain less weight than the geriatric patients who hardly gain weight with olanzapine at all. So, so we had a 10-pound weight gain in the olanzapine group over the first 8 weeks, which is, quite a large weight gain, and in my view, made this more of a proof of concept study, showing that an antipsychotic medication could be beneficial when needed, but this particular antipsychotic medication is probably not a good first choice because of the weight gain. There was a study done in Australia of risperidone versus placebo. This was embedded in a more complex design that involved cognitive therapy. Low doses of risperidone, 0.5 to 2 milligrams, and adherence was poor in this particular study. This shows the survival curve, and if just try to, there are 2 lines that are gray, a solid gray line and a dotted gray line, and those are the ones where there is a risperidone versus placebo comparison. And I think you'll appreciate if you can focus on those two lines, which are most easily seen by themselves right in the middle of the graph around 800 days from entry. Those two lines are basically parallel all the way through. So there was no effect on conversion to psychosis of low-dose risperidone in this study. And the symptoms didn't show anything either. However, unlike the olanzapine study where the symptoms were measured frequently over time, this study only measured well, they measured them monthly, but they only reported the results at the end of the year, and then only in the patients that completed a year. And this particular kind of analysis is prone to having the placebo patients who remain in the study, because a lot of them tend to drop out, and the ones that remain tend to be the ones that are doing really well. And so a completer analysis after 12 months like this is could miss a treatment effect. This is an open label. I'm not counting this as one of the three controlled studies, but just within baseline to endpoint here at 8 weeks, you see that with this open label study, aripiprazole improved almost everything in the patients. Of course, after, even without treatment, the patients do tend to improve over the first weeks and months of therapy, so these results are uncontrolled and must be taken with a big grain of salt. But the adverse events are interesting. So now weight here is right in the middle, is measured in kilograms because this was a British journal and they wanted it in kilograms. So it's about 3 pounds over 8 weeks for aripiprazole. Aripiprazole has a reputation, as you know, of not being associated with much weight gain. Most of that reputation comes from patients who've been on other antipsychotic medications and had gained weight switching over to aripiprazole. It does have a lesser but still some weight gain liability when it's the first antipsychotic that a patient has been on. So the third placebo-controlled study I'm going to talk about in a little bit more detail. It's not published, though. Because it's not published, this is a ziprasidone versus placebo study. I was the principal investigator on this study. I need to get the data out there, but it's still not published yet. There were 6 sites. You can see that, again, the active treatment dose was lower than the placebo dose. And we haven't analyzed the adherence data yet. And again, all patients receive supportive therapy at each visit. These patients could have been on antipsychotic medication in the past, but not in the past 3 months. They were dosed flexibly, 2 divided doses. Because of the concern for QTC prolongation, there are a lot of EKGs in this study, and they were read by a central cardiologist. We had intended to enroll 80 patients, but recruitment pooped out after a while, and we finally ended up with 51. 23 were analyzed, allocated to ziprasidone, and 27 to placebo. I think I'm just, in the interest of time, just going to skip these baseline comparisons. So this, or what happened to the SOPS positive symptom subscale, which is a sum of the 5 positive symptoms from the SOPS, which is part of the SIPS interview. And the narrower lines are each individual subject's individual trajectory, and the bold lines are the overall group trajectory or slope. And this was from a mixed regression model. Among the rating scale scores in this study, only the SOPS positive subtotal was statistically significant, but it was statistically significant. So the patients improved. I think you can even appreciate that from this figure here. Patients improved more on ziprasidone than on placebo. There were relatively few conversions in this study compared to the olanzapine study, and no statistical significance on conversion outcome. EKGs were perfectly normal throughout the study. And we investigated that thoroughly. And unfortunately here in this slide, because we did the analysis of symptoms on the slope, the analysis of the adverse events are the same way, but there wasn't a significant difference in the weight slope with ziprasidone, and unfortunately I don't have those raw numbers to show you handy like I did for the other study. So, but I think there was a similar effect as to aripiprazole overall, even though it doesn't show up in this slope. So there are limitations, in particular that it's not published yet, and the low conversion rate. But this is the third placebo-controlled study. So we now, 2 of the 3 studies show a statistically significant benefit on positive symptoms. And the other study, as I mentioned, which did not, had some analytic, in my view, analytic flaws, which may have contributed to its not showing an effect, in addition to the poor adherence, medication adherence. So just to move to recommendations for clinical recommendations for antipsychotic treatment in clinical high-risk syndrome. Most people in the field feel that antipsychotics are generally not recommended for routine first-line treatment, even in low doses. And the reasons for that are because of side effects, metabolic side effects, weight gain, diabetes, risk of tardive dyskinesia, sedation and akathisia, and the fact that there are safer treatments which can be employed instead of antipsychotic medications in many settings, such as cognitive behavior therapy. However, the placebo-controlled studies do suggest that patients can benefit when the medications are indicated, and the times that they might be indicated, in my view and in most people in the field's view, are when there's rapid deterioration, when there's risk of self-harm or aggression, and when there's very substantial distress or impairment and other treatments are ineffective or unavailable. And this summary here is pretty much consistent. Well, I summarized that already, that there is some evidence for efficacy when they are indicated, and the limited indication of antipsychotics medications in this CHR syndrome is consistent with published treatment guidelines, which primarily recommend, they're mostly old now, they haven't really been updated in the last few years, but they mostly recommend careful assessment and monitoring, and antipsychotic medication only when there's rapid deterioration or suicide or regression and so forth. So now we're going to move into the antidepressant area, and I'm going to show you similar data, including some unpublished data here as well. So before you saw the 30% rate of antidepressant use at baseline in the Naples sample, and here are some other samples from around the world, and it's 30% is probably modal or median, I would say, across this group. The highest rate was 40% from, I believe that's an Asian sample, and the lowest was 14% from a sample in southeast London. Despite this, this is the most commonly used medication class in CHR, and interestingly, despite its common use, there's not a single randomized study of, not even one, of antidepressant use in CHR. I don't think we have a lot of observational data, and in my view, we haven't got as much mileage out of it as we should have, and we need to work on this harder since we don't have any randomized studies to show. But there are two published observational studies, both of which showed that that the patients who are on antidepressant at baseline are at lower risk for conversion, and a third one which shows that patients receiving antidepressants at some point after baseline are also at lower risk for conversion. And I just want to unpack this a little bit because I'm not sure that this is true, and in my view, you'll see that I do not recommend using antidepressants if the goal is to prevent conversion. On the other hand, if the goal is to help with their current symptoms, I do recommend them. So I'll show you why now. Why I don't trust these. I clicked the wrong button. Sorry. Why I am not trustful of these observational studies. So if you take a group of patients who are currently on antidepressants and you pull them out of the natural population, you're selecting. It's basically selection confounds, and do they explain the apparent effect rather than the treatment itself? And there are definitely selection confounds in these naturalistic studies. So looking at a baseline current antidepressant group selects for people who have stayed on antidepressants and are therefore responders, so they're a good outcome group almost by definition. And they may be a good outcome group because they have access to antidepressants compared to patients who don't. And it's possible that patients who have indications for antidepressant prescription, like patients with comorbid depression, may actually have a good outcome relative to conversion as opposed to a poor outcome relative to conversion. So for all three of these reasons, it's possible that a group of patients who are already on antidepressants are a good prognosis group independently from the effects of the medication. So just as a graphic of this, so if you start with the patients, this top line, if you start with the patients who are on antidepressants at baseline, they tend to have been on them and stayed on them on average, and the patients who did poorly on antidepressants and stopped them end up in your control group. And so a better option is to in a naturalistic design, is to study patients who you got the bottom line, that you were able to get a baseline assessment on before they began antidepressants for the first time. And I'll show you an example of that. So I'm repeating myself here. We looked at our Naples 2 data, and we also found that baseline current antidepressant was near protective of conversion. In our sample, it wasn't quite significant. But as I've said, I don't think the baseline treatment is where we should be looking. There is such a thing known as the new user or inception cohort analysis. It excludes the patients with a lifetime history of previous treatment, whether they did well on it or are still on it. or whether they started it and stopped it in the past, are still excluded. And then it identifies those who start versus those who don't and compares their outcomes. And we've done this in our Naples 2 sample. And one of the things this analysis allows you to do is to use your baseline data to study who gets started on an antidepressant. And then you can use those to adjust for treatment effects. Demographics did not predict who got started. Current major depression, comorbid, and current anxiety disorder, comorbid, both predicted who got started on antidepressants. So I would say these community prescribers whose treatment we were observing in Naples it was rational prescribing in general. There's no the other baseline treatments had no effect on the new prescription of antidepressants, and symptoms that tended to be depressive symptoms, especially this Calgary Depression Scale, that was the strongest predictor, also predicted who got started on antidepressants. And also patients who had lower social functioning tended to get started on antidepressants. And so then when you enter all of those predictors of antidepressant start into a multivariate analysis, the only one that's an independent predictor is baseline depressive symptoms. And so then we also looked at the predictors of conversion, and in the interest of time, I'm not going to go into that anymore. And then did the antidepressant start conversion analysis, and both the unadjusted analysis and the analysis adjusting for those baseline selection factors, neither one of them showed that antidepressants, new starts of antidepressants prevented conversion over a 6-month time frame. And the symptom analyses, these are the symptom analyses of the Calgary Depression Scale for schizophrenia. And notice here there's an interesting interaction between the baseline depression scale score and the treatment effect. So we look at those separately in two groups. The ones that had a high depressive symptoms and were started on an antidepressant improved significantly compared to the ones that had a lower Calgary Depression Scale did not improve relative to the no antidepressant patients. No findings for anxiety, no findings for SOPS scores. But the social functioning improved in everyone, not just the most depressed patients. So it looks like the antidepressants overall had a beneficial effect on social functioning compared to the people who did not start antidepressants. I'm sorry, I'm not able to pay attention to the chat, so we'll get to that during the discussion. Limitations are this is work in progress and not published yet. But the antidepressant prescribing in the naturalistic setting did seem rational. Predictors were what you would expect: depression and anxiety diagnoses and symptoms and low social functioning. And the antidepressants help depression in the most depressed, and they also help social functioning, but not conversion. This fancy analysis notwithstanding, randomized evidence is still the gold standard, and I think we really need randomized placebo-controlled studies if we can get someone to fund them. Don't have a lot to say about mood stabilizers, as you can see. Haven't been used very much. I'd be very interested to hear whether there are any prescribers out there that do use them and what effects they see, particularly, say, with Lamictal. Stimulants. So about 5% of Naples people come in on stimulants. Most of you probably know that in 2007 the FDA required that warnings be added to the prescribing information labels for stimulants, a warning for emergent psychosis. This was based on these analyses here, and I think you can see from the highlighted fields that it's kind of interesting that even though the label was for emergent psychosis, the events that they captured were for either psychosis or mania, and actually a large proportion of these events that they detected in this large group of a large group of trials submitted to the FDA. A lot of them came from did not come from amphetamines or methylphenidate, but rather from modafinil, and especially from atomoxetine here, so which is not, in my view, is not a stimulant. So I just point this out as a little bit peculiar about the warning, although of course as prescribers we have to be aware of the warning. So recently there was a large administrative database study published in the New England Journal. It showed that there were 1 or 2 new episodes of psychosis per 1,000 person years of drug exposure. And that was a statistically significant difference, more with amphetamine than with methylphenidate. But these are pretty low rates, and they're not. This study was done in 13 to 25-year-olds who were enrolled in very large healthcare plans, and a rate of about 1 per 1,000 patient years is pretty close to the natural population rate. So although these rates are a little bit elevated, they're not astonishingly elevated. And so that, in terms of risk benefit ratios for individual patients, the fact that although the relative risk was a little bit up, the absolute risk remained quite low, needs to be taken into account. And interestingly, since we mentioned modafinil, this is a figure from Christophe Correll. It's about schizophrenia, and it's about adding clinically available medications. It's a meta-analysis of adding clinically available medications to ongoing antipsychotic medication. And interestingly, the SNRIs had the biggest benefit when added on in patients with chronic schizophrenia. But modafinil actually showed it was still clinically significant, a much smaller improvement, but still clinically significant improvement. So similar to what was seen with aspirin and NSAIDs. There are a large number of other studies of stimulants and their risk for emerging psychosis. They haven't really been well summarized in meta-analytically, in my view, in part because the methods are quite variable. One of my colleagues here is reviewing that literature now, and so far he thinks that it's pretty much inconclusive, even though, of course, high-dose abused stimulants cause psychosis without question. but the issue about whether regular doses of medically prescribed stimulants for attention deficit disorder causes psychosis is still, at least in my view, still an open question despite the FDA warning. So I think that would be fun to discuss if people want to. Benzodiazepines, there's very little information about benzodiazepine use too. There might be some theoretical reasons to support it. However, in this particular, I don't have all the drugs that didn't work in this particular Correll meta-analysis, but benzodiazepines had zero effect in chronic schizophrenia, so maybe less likely to be helpful in CHR. Just a little bit about investigative agents. The first study of an omega-3 fatty acid was dramatically effective, and only 3 months worth of treatment had an effect that lasted for well over a year in preventing psychosis, even though the treatment was stopped after 3 months. However, there have been at least 3 replication attempts which have failed to show a benefit from, or at least an important benefit from omega-3 fatty acids. These studies have tended to have lower conversion rates than this first study. And other than that, I can't explain why the first study was so dramatically positive and the next 3 were not. If any of you have thoughts on that, I'd be interested in whether you're using it despite the 3 failed replication attempts. There's interest in anti-inflammatories these days. This just reiterates what I showed earlier, that aspirin probably has the best effect size in chronic patients and might be worth studying in CHR. Glycine, which is a supplement, also has anti-inflammatory effects in addition to its NMDA effects, and there's a tiny bit of evidence from a very small double-blind study that glycine might be effective, and from an open-label study, and a larger double-blind study, but still very small, study of a glycine-like drug called D-serine, also a supplement. These small studies really haven't been followed up on, and although they are technically available because there's supplements, there are problems with, the patients have, it's a little bit hard to manage this in your practice using these medications, because you have to find a good source for the powder, and they're very, very large doses, so you can't just give pills. You have to mix powder up with liquid, and the patients have to weigh out the powder, and they have to purchase it online, and it's complicated, and so not too many people are interested or willing to do that compared to the convenience of prescription medication from a pharmacy that is paid for by their insurance company. So that's really all I have. I intended to leave a little more than the 15 minutes for questions, and so I think maybe since I do have a little bit more time, I'll just say again that overall the evidence suggests that for the average patient at clinical high risk, the risk-benefit ratio of antipsychotic medications is not tilted toward use. However, in the most ill or highest risk patients, there is evidence to suggest that it will help them. And then antidepressants, which are commonly used, do seem to be effective for the most depressed patients, and seem to help social functioning also in just one analysis, but have no effect on, in that one one analysis don't seem to have any effect on conversion to psychosis. Thank you so much, and let's do the questions.
Thanks, Scott. Really appreciate your wonderful presentation. I echo Cheryl's comment about what a wonderful review you've shared with us. We have a couple of questions. Initially, one comment actually that Cheryl raised was her experience actually identifying more people with medical and neurological type issues than it seems like has happened in your experience. And I think one of the things I wonder if you could just maybe walk through for everyone a little bit is what type of medical workup do you generally do? And I know you mentioned doing the imaging as related to research, but what are generally the components you do in terms of a medical assessment of people coming in at clinical high risk? Are there times outside of research when you would recommend turning to imaging or similar types of studies?
Yeah. Well, in our hands, we just have we use a psychiatrist for the prescriber, and we have the psychiatrist take a medical history at one of the first visits, and also order a set of screening laboratories, and that's what we do. I think that the routine use, say, of an MRI, it did detect that one brain tumor, which was a good thing, but I think even in first episode, I think many people, probably practice varies, but I think overall I would say it doesn't seem to me that people feel that a routine MRI is indicated in every case. And this goes against what I was taught in medical school, that every schizophrenia patient deserves a CAT scan. In those days we were doing CAT scans. Every schizophrenia patient deserves at least one CAT scan in their life. But I don't think that that's actually most people feel that that's cost effective. So I'd be interested in other people's opinions on this, though.
Thanks. One of the other questions I guess I was wondering about was when you generally are looking at utilizing antidepressants for the people you're seeing with clinical high-risk issues, are there generally certain groups of antidepressants you're looking at utilizing that you feel like are more effective or better to start with as a first-line antidepressant?
We don't have really strong opinions on that. I think in general they work pretty much about the same. There is maybe a little bit of evidence that the SNRIs may be slightly more effective on the average than the SSRIs, but and this would be for depression, not for depression and CHR specifically. But a lot of times the choice comes down to a patient preference, and they'll say that their aunt was put on Celexa and did well on it, and so we tend to that this is just there may be a little bit of evidence of family history of response running true to a particular drug, but it's also, of course, something that good to give the patient something that they're familiar with and positively disposed to, and to take advantage of the placebo effect as much as you can in clinical practice. We hate it in research, but we love it in clinical practice. And so I wouldn't have any, other than that, any particular specific recommendation myself.
Okay. I don't know if you can look down and see the question Cheryl has just sort of been asking in relation to antipsychotics, which was somewhat similar, but you had those criterion situations where someone is close to moving into a psychotic process, or the other situations where an antipsychotic might be warranted. Given your experience and the studies you shared with us, are there particular antipsychotics you generally find best to begin with in those high-risk situations as a first-line choice?
I'm going to say yes to that, and I'm going to hedge this by saying, number one, this is just a purely clinical recommendation, and number two, I don't have any financial connection with the company, but we primarily start with lorazepam, Latuda, these days, and we find that it's very, it's fairly well tolerated in terms of most side effects, including weight gain, and that it's only once a day drug, which is a good thing compared, say, to ziprasidone, and although there is, the only thing difficult about using it is needing to educate the patient about taking it with a meal, or else 2/3 of the medication won't be absorbed. But they usually get that, and we usually give it with the evening meal and find that it's not that sedating, and that they're able to get their homework done after dinner, and when they take it with an evening meal, and do pretty well with it. So I'm sorry if this sounds like an advertisement, but that's usually our go-to first drug at Prime for when we do, in the unusual cases where we do start an antipsychotic.
Well, it's really helpful, actually.
And we do the same thing upon conversion as well.
Mm-hmm.
We actually have more of those that are started after conversion, probably.
Right. Thank you. Do the omega-3 studies you mentioned, and the ability to replicate that initial result, I don't know, I think there was a point for me where I was starting to regularly prescribe omega-3 oils for patients, and I would say for the most part I haven't stopped doing it, even though the studies have been less conclusive, and I wonder if you have any thoughts about that, or what your experience has been within your clinic, and I don't know, for others that are attending as well. Is that a choice you're continuing to make, or people stop doing that generally? What's your experience around them?
My personal experience was, very early on, we, I think even Cheryl, when you were still at Prime, so this was a really long time ago, we did a small open-label trial, only 6 patients, with omega-3. And in those days, we had, we just started our clinic, and there seems to be an effect when you first start to sample from a population and pull in CHR patients from the population. You tend to get the ones that are the most high risk right away. And so we had a lot of conversions in those early days, and we had 3 of the 6 people I started on omega-3 converted, and so that one of them a week after they stopped it, but they only were on it a fairly short time. So I felt, and one of the patients I remember very, very well, because both his father and his mother had been schizophrenic, and he was just classic, and it didn't stop it. So I never felt that enthusiastic about it myself, and so I haven't really used it. But I know other people. On the other hand, there was one patient that from those days that Barbara remembers as well as I remember the ones who didn't do well, and that patient loved it and went into remission and stayed in remission, and he calls up Barbara Barbara Walsh, our clinical director here, calls up Barbara once a year or so just to touch base, and still taking it now, almost 20 years later.
Wow.
Are other people able to join and to speak, and maybe other people would like to? I'm sorry, I can't pay attention to the chat. So
No, it's fine. Other people are able to maybe type but not speak because of the way it's structured around the
well, maybe I'll try to
microphone. So the one other question, if you can look over on the presenter side in purple, Cheryl had another question really around inclusion criteria for the one RTC you mentioned. I wonder if you could address her question related to that.
Yeah, for the ziprasidone, that was done before the development of the risk calculator, and so they were all comers, and that's probably why the conversion rate was low. So that study needs to have been published for a few years now, Cheryl. So apologize for that.
When you mentioned safer alternatives back at the beginning to antipsychotic use for people with clinical risk for psychosis, you mentioned CBT, and we've had some presentations on that, and we'll continue to. Are there other safer alternatives that you would urge people to think about in addition to CBT in terms of support rather than antipsychotics for early intervention?
Well, I think even a supportive therapy I think an argument can be made that that many patients don't, maybe a quarter of them don't need anything except a supportive therapy and will go into remission, within a few months of their initial presentation. So with that, that's certainly a safer alternative. And you probably know, Steve, about the one family therapy study. Well, I should say individual family therapy study. That was a randomized controlled trial. And of course, there's all the multiple family group work that Bill McFarland's group has proselytized for and advocated for. I should say. And those are obviously safer alternatives too. I don't think we actually, for preventing conversion, I don't think we have a safer alternative right now. But I hope that we will, and I hope that we're able to, as a field, I hope that we're able to generate some large clinical trials to guide future practice, because our patients really deserve it.
Okay. Well, thank you. And thank you, Cheryl, for your comments and questions as well. And would love those of you that are also listening in to feel free to jump in with your questions. Cheryl's also now asking about thoughts related to TMS or transcranial direct stimulation or cognitive remediation or other kinds of interventions that you have a sense for as being supportive or successful with people who are at clinical high risk.
Well, maybe Cheryl has more experience in these areas, and we should invite her to give a follow-up talk. Innovative treatments in CHR. If you don't mind me suggesting a title for you, Cheryl. we don't have, I don't have any experience with transcranial magnetic stimulation, and only limited experience with cognitive remediation. We just had trouble. We did try it. I mean, not maybe as aggressively as we should have, but for the cognitive remediation, we did try to get a program going, and we just had very poor follow-up with the patients. They, at least the positive science version that we were using, the patients hated it, and they said that it was, they felt like they were first graders again, and so probably there are, the online ones. What's the one that's so popular? Steve, help me with the online cognitive remediation that is very popular these days.
Yeah, the truth is, I don't know.
Well,
someone else maybe type it in and help us out.
Someone else type it in. I mean, there's one that's very popular that a lot of people use to try to keep mentally sharp, and I think that's more popular. But as far as I know, it hasn't actually been tested carefully in CHR. I could be mistaken about that, but that's my. I'm trying to look at the public chat for somebody. It'll probably come to me.
If someone typed in luminosity, but I'm not sure that's.
Yeah, lumosity. Yeah, lumosity is called. Yeah. So that.
Thank you, Candy.
Thank you, Candy. So that's I think definitely worth a try, and apparently people actually like doing it, and so that's a good thing.
Okay, any other, I don't see other questions or comments. Let's take one last minute to see if anyone has anything else they want to ask Dr. Woods about. And if not, let me just thank you for your
applicant was good. Hi.
Someone's typing now, so we'll just give them one more minute.
Was there any? Did anybody have any comments about stimulants? As we,
oh yeah, I saw you had that there.
I mentioned that because we, just the other day we had somebody who came to us right a month after their outside prescriber had insisted on stopping the stimulant because of the FDA warning, and with their new emergence of psychotic symptoms. They've been taking it since age 7 quite successfully, and then and they and the family felt the loss of the benefit and worsened school performance very strongly, and so I felt terrible not knowing as much about this as I should, and felt that it was difficult to, it was a difficult way to balance the clear evidence of benefit with the uncertain, to my mind, uncertain evidence of harm. So,
well, I'd be anxious to hear what other people might share in response to that. I think I, generally have had the same concern as you, and if it's someone who's been on these medications for a fairly long time, consistently and stably, I've generally not tended to stop things at that point within that process. But I'm not sure what other people's experiences have been related to that. It did raise for me, though, another question that I wonder if you have any experience about. I've had now a number of young people I've started to see who are interested in transitioning from female to male, and questions have come up around testosterone and testosterone injections and concerns related to people at clinical high risk for psychosis having risk of more issues as they would start testosterone treatment. And has that come up for any of the young people that you've worked with at this point at all?
Well, the gender issues, of course, are pretty common now, both female to male and male to female, but I don't think we've had any actually begin testosterone treatment with us yet. And there is, I guess I would need to research this, but the only thing that comes to mind is the slight male preponderance in the incidence of schizophrenia. It's very slight. It's like 52 to 48%. I don't think I'd be, based on that, I don't think I'd be that worried, but perhaps you have more information?
Well, not particularly. I know some people have raised some concerns at times about a risk around this. And so I was just curious if you'd had any experience, and I've seen at times people raise questions related to testosterone and increasing risk for psychotic processes. So I was just curious about that. We've had two more questions come up, Scott. One of them is around after Latuda, what's the second choice? Generally, if that hasn't been successful. And then another question was around, and thank you, Cindy, for your question around any experience related to neurofeedback or biofeedback that's been helpful with young people with these issues.
That sounds like a good topic for a potential future talk also, the neurofeedback.
All right.
But I think we probably would go to aripiprazole next on the average. We don't, I don't know, maybe we're old-fashioned or something, but we don't prescribe a lot of some of the really newer ones like cariprazine, for example. It doesn't get a lot of use around here, so.
Okay. Well, why don't we leave things here and just say thank you very much for a very comprehensive presentation. Thank you to Cheryl and others for your involvement and comments and questions. We really appreciate it. And we hope you will, download the presentation if that's of interest to you. And we'll look forward to following up with you on the next presentation. I know that we have one coming up next week through the PepNet partnership for folks. And then as Tiara is reminding us, please do the survey if that would be okay with you so that we could get your feedback and make sure these are more effective over time. And again, Dr. Woods, thank you so much for your time. Thanks to all of you for attending as well. And have a wonderful afternoon.
Thank you.